programs. We have a very robust emergency department engagement program where we do Suboxone inductions in the emergency department at a Memorial Regional Hospital. So we're just really glad to talk to you because we're very passionate about preventing child abuse, preventing neonatal abstinence syndrome, and how we can do that by treating addiction, right? We're going to go very fast, but hopefully we'll have at least 5-10 minutes at the end to ask questions. The other thing is that Sam will be emailing everybody a PDF of this PowerPoint, has our information on it. We hope to use this as a platform to have other discussions in the future going forward. So one of the things that we're going to talk about are just really looking at the reward pathway. So what are the neurological underpinnings of addiction? We're going to talk about opioid use disorder and how it's diagnosed. We're going to talk about different medications and what medication-assisted treatment looks like. And then what are some strategies that are effective? So how do you evaluate a good MAP program versus someone just being prescribed a medication?
So I'll discuss this slide. One of the things, I didn't introduce myself. I'm Dr. Augustin. I'm a psychopharmacologist. I'm also a toxicologist. And I love talking about this particular side, but just to acquaint everybody, we're dealing here with the 3 waves of the rise of the opioid overdose deaths. Many of you probably have seen this, something that's available online with how they characterize the waves. On the bottom, you see wave 1, wave 2, wave 3. So let's acquaint ourselves with wave 1, resulting in a rise in prescription opioid-related deaths, secondary to overprescribing, followed by wave 2 because of the legislation that we had across the country, particularly in Florida, with the decrease in the pill mills and things of that nature, resulting in individuals who have an opioid use disorder looking for something to use, and an increase in rise of heroin use, secondary result, heroin deaths. The other thing I didn't mention in the last presentation, we also had a rise in heroin overdose deaths, but also infectious disease, including HIV and hepatitis C related diagnosis, and ID related to osteomyelitis and endocarditis presentation. So that's something we never talk about. And then lastly, wave 3, which is a rise in synthetic opioids. Many of you have heard of fentanyl, carfentanil, acetylfentanyl, methylfentanyl, all these products which are much more potent than heroin and oral opioids, meaning a very small amount can give an individual the high that they're looking for, and a very small change in that amount can cause an overdose and death. So really, you're seeing a variety of things that are occurring during this phase.
And this slide, you can see, and this is going to be a common theme, is that the data that we have lags because we don't have up-to-date information, especially nationally. But this ends in 2017. In 2017 and 2018, we started investing heavily. We got federal funding for medication-assisted treatment. So we really started to put together programs that specifically targeted people with opioid use disorder to try to get them into treatment, but with the use of medication-assisted treatment, buprenorphine and Vivitrol in particular in the state of Florida. One of the things that we know is that those programs worked. We started to get that curve flattened quite a bit, and we started to see a dent in those numbers decreasing. However, now because of COVID, since March, we've seen increases in the number of opioid-related deaths, increases in the number of people presenting for with drug overdose to our emergency departments. So just something for your radar to start keeping track, and we're seeing it in practice here in our emergency department. We see waves where like multiple people from one household come in for an overdose. So we know that there's something going on in the community. We don't know exactly what it is yet.
And I wanted to add one more piece, and we're going very fast.
Forgive us.
We like going fast, one of the things I want to bring up, and we didn't say it last time, go back to the slide, is the impact of COVID. I mentioned the impact of COVID-19. If everybody, it is difficult for people to see large-scale pictures of policy, and you can imagine looking at the rise of fentanyl. That rise corresponds to an increase in influx of fentanyl and fentanyl-related analogs from China. Why China? Because it's easy to manufacture in China, because the products necessary to manufacture anything illicit is not illegal. It is illegal in our states, Hence, it's easier for large companies to actually use and transport those things across the world without having any significant consequence. So nevertheless, that rise that we saw in China, the rise that we saw in the influx from Mexico has obviously decreased because of COVID. So we have a little bit of a flux. We don't know what we're going to be seeing in the next few months to years. So just pay attention to that. And then lastly, what I did not mention in the previous discussion is COVID has had a huge impact on our healthcare system, on the community. One of the things that we want to send home the message is that our healthcare system, we didn't stop servicing our patients. Our doors have been open the entire time. We saw a large increase in all aspects, meaning psychiatric and substance use disorders. So I just wanted to let everybody know that we are still open and operating and fully functional.
The other thing is in this slide regarding the synthetic opioids, that you know that they're not just in opioid or heroin or fentanyl, but we're seeing these analogs in cocaine and methamphetamine. So they're mixing this with a bunch of other drugs. So it's very hard to get a clear picture. Sometimes people are presenting with an opioid overdose, and they didn't even think that they had used an opioid. So just something to keep in mind. Why can't I? There we go. Okay, so just this slide really is to bring home the point that we really started prescribing opioids in high doses for the treatment of chronic pain. In the last 3 or 4 years, we've realized that that is not a good practice, and that treating someone with chronic pain with long-term use of opioids is actually not good, and it's worse for them, and it's not even effective. What we know now is that the majority of people with opioid use disorders currently started by taking a pill. They started by having some opioid prescribed to them or using somebody else's prescription. And the majority of them to relieve physical pain, most of them, if they weren't prescribed, they got that medication from a friend or relative. So what works for treating all of these rampant addiction and substance use disorders that we're seeing in our community? We know that expanding access to medication-assisted treatment works, but that medication is not a panacea. That means that just a medication on its own is not going to treat someone's substance use disorder. We need to focus on keeping people in treatment, and the old adage of 3 strikes and you're out is not working. So people this is a chronic illness, people do relapse, and helping them to stay in treatment is really important to their long-term recovery. Making sure that you're providing treatment, or that treatment is being provided in an integrated fashion, that you're looking at the whole person. So it isn't just treating an addiction, but it's all of what kind of medical issues are there. And I know that it's hard because sometimes it's difficult to find providers that deal with someone who has psychiatric issues as well as their addiction, or that has comorbid medical issues as well as the addiction. So that hopefully that way of treating people is changing, and that we're going towards something that is much more inclusive and integrated. Because the other piece is that people with substance use disorders are high risk for suicide, and they're high risk for having other psychiatric comorbidities, not just medical. So those need to be addressed so that the person can get well and start to really form a life in recovery. And then also prevention is really important. That screening, early detection of psychiatric issues. One of the things that we talk about for preventing neonatal abstinence syndrome is talking to women of childbearing age who have substance abuse issues to think about going on a long-term contraceptive in order to avoid an unwanted pregnancy. So that's like a really, really far back prevention strategy, but we know that it does work. And so what are some fundamental concepts? We're going to talk a little bit about the reward pathway.
All right, so once again, a very difficult topic to do virtually, but I'm going to do my best. I mentioned last time, this is something I could probably talk about for over an hour, so just follow along.
You're doing great.
Thank you. So look at the 4 pictures, and we're going to start off with the top left. And I know it got cut off a little bit here, but the top left picture looks like a brain, hopefully. And we're looking at a pathway, and getting really nitty gritty, you've seen white on the bottom of the first picture on the left says ventral tegmental area. And then you see more towards the top, another area called the nucleus accumbens, and then you see in the middle, something called the amygdala. We'll talk about those in a minute. The ventral tegmental area and nucleus accumbens are areas in the brain that are what we call relegated to the reward pathway. The reward pathway is an area in the brain, and now if you look at the picture to the right, an area of the brain that gets activated regardless of what you're using that could be rewarding in nature, whether it's illicit substances like heroin, alcohol, benzodiazepines, barbiturates, and on the left-hand side, alcohol, cocaine, amphetamines, opiates, THC, PCP, ketamine, nicotine, any of those activating the reward pathway, therefore resulting in an increase in dopamine. Dopamine being a pleasurable neurotransmitter. So now, I acquaint you to the two pictures on the bottom. And actually, there's probably a percentage of those in the audience, more so to the left than the right. The left picture, which is activating the reward pathway, is literally by looking at that picture of that chocolate cake.
Delicious chocolate.
And if we start describing it, you say some of the fudge, say some of the chocolate, you say some of the top, you say smooth, you say warm, fudgy, brownie. Out of a sudden, you don't realize it, but you are starting to crave something that triggers a release of dopamine in the brain. Now, the same thing to the right, you see somebody doing a lot of cocaine, that is actually causing an increase in dopamine. So all these things, we'll go to the next slide, all these things cause an increase in dopamine in this pathway called the reward pathway. So as we continue on in this next picture, and this is a real simplistic description of that pathway. The top is a prefrontal cortex, followed by the next box, which is the nucleus accumbens, and then the next box, the VTA, ventral tegmental area. So the middle and the lower box are known as the reward pathway. Anything that triggers the reward pathway, I already mentioned, causes a release of dopamine. That dopamine makes one feel really good, makes one feel pleasurable, makes one feel happy and elated, and it causes one to then remember the event. That remembering of the reward pathway event and the experience is something that gets engraved in an area of the brain called the amygdala. And if you look on the left-hand side, you see a little picture of the amygdala. Essentially, the amygdala is located on the side of the brain area. That area of the brain, the amygdala, recalls and remembers a particular experience. And I like giving the description of somebody who likes to smoke cigarettes and drink Coca-Cola. And every evening they smoke cigarettes and drink Coca-Cola. And this is the normal, and that smoking cigarettes, nicotine, releases dopamine in the reward pathway, making it pleasurable for them. And that gets engraved in their amygdala. And then whenever they walk into a room without cigarettes, and they see a can of Coca-Cola, without them knowing, without them wanting, the amygdala is going to identify that Coca-Cola and immediately cause a small increase in release of dopamine in the reward pathway, causing that individual to then start craving that cigarette. Immediately by visualizing that Coca-Cola, they will crave and they will want to have that cigarette. Just much like some of you may have seen that chocolate cake, a little bit of dopamine was secreted in your reward pathway by the amygdala, causing you to maybe salivate and say, I need something to eat. So that's the same experience that happens when it comes to reward pathway. And I always like to say, what happens the more you use the product and the earlier you use it in age, the more things get engraved in the amygdala, causing that remembrance in the reward pathway. And then we're going to go ahead and discuss the wrap part discussion.
So in terms of the amygdala, really one thing to remember too is that exposure to childhood trauma and abuse shapes the amygdala. So makes a person more susceptible to drug abuse.
And one of the things that we have to answer, and these questions come up, say basically, if I've had that in my amygdala engraved, do I have an opportunity to reverse it? And the answer is yes. The best opportunity to reverse the amygdala transcription process is time. Time away from that experience is what allows us to revamp that amygdala wiring. Specifically, time free of anything that triggers that reward pathway. Meaning, if you have somebody that's still getting the pleasurable effects from that opioid in the reward pathway, whether it's through MAT or non-MAT, that's triggering the reward pathway, causing that amygdala to still be engraved. So that's very, very, very important concept. Lastly, what are the things that trigger this pathway? The amygdala, people, places, and things. Hence why we always say, don't go to those locations. Don't use a particular products, whether it's
new set of friends.
New set of friends, and then people. So people is very important. She mentioned friends, and we always say you have a very, very challenging time when you have people in relationships, because the moment they're in relationships and they use together, the moment they see that person's face, no matter what they want to do, it's going to cause them to recall that experience they had using with that individual without that me being knowing it. Hence why couples have a very difficult time getting clean when they're together.
So although this slide seems really simplistic, obviously the concept is that this is really a complex issue. A lot of factors lead to addiction, and what happens is one of the studies that were done in the 60s and 70s, they looked at, they had a little rat, they put a rat in this is called the Skinner box, and the rat had access to food, water, and cocaine. And I think they also did one with heroin. So what they found is the rat on your left-hand side that was in that Skinner box in that experiment did, and I'm sure a lot of you have heard about this, they did the cocaine or the heroin until they died. They didn't want water, they didn't want food, all they did was the drug. What they found when they went back and they looked at what was going on, the researcher Bruce K. Alexander, he said, what if we built a different place for the rat? What if we did Rat Park? And so they created an experiment where there were multiple rats, they were hanging out, they had all their little rat fun, they had different stimulating environments, as you can see on the right hand side, and they also made the heroin, cocaine, water, and food available to them. What did the rats in Rat Park do regarding the use of the drug? They went, some of them might have tried it, but they didn't go back to it. What they did was continue to, they were in the stimulating environment, they were happy. And what does that tell you about addiction and environment? So we know that there's so many factors that contribute to somebody having a substance use disorder and becoming and having to deal with addiction. So looking what environment they grew up in, looking what their neighborhood looks like, look at what access to care looks like, which is one of the reasons why it's so important that we have these types of conversations when we look at what creating a recovery-oriented system of care looks like in Broward County. We're in the process of continually creating places where recovery is possible, and our own little Broward County version of a happy Rat Park. This is just a quote from Bruce K. Alexander. He ended up writing a book about his experiences, and he really looks at how chronic isolation, and think about what's going on right now, and how substance use disorders are going to be exacerbated in this current time, because we're looking at a really a possibly very bleak social environment where addiction is going to become more of a problem than it already is. This next slide just talks about the opioid use disorder. Some of you may have heard people referring to OUD. This comes from the DSM-5. What one takeaway from this slide is, number one, as increase of opioid abuse in the community has caused increase in neonatal abstinence syndrome rates. This is old data. Last was looked at 2004 to 2014. Obviously, we're way past that. And we believe that the data currently is every 10 minutes a baby is born with neonatal abstinence syndrome. So these are the diagnostic criteria according to the DSM-5 for opioid use disorder. I'm not going to go into much detail. If you have questions, we can go over it later. We can tell you that if you look at this list, two to three symptoms is a mild, in terms of severity is mild. 4 to 5 symptoms together is moderate, and then severe is the person has 6 or more symptoms. So look at all of the areas where you have issues with opioids. According to the diagnostic criteria, it can tell you how severe someone's diagnosis might be. Tolerance and withdrawal, just something to keep in mind in terms of what we see, physical withdrawal that the person experiences, and one of the ways to look at that is the concept of toxidromes.
And before we get to toxidromes, I didn't mention this in the last presentation. We oftentimes have a difficult time describing what happens with tolerance. And I like to have the discussion with tolerance with benzodiazepine discussions like Xanax, Klonopin, Ativan, Valium. Excellent agents to utilize for the treatment of anxiety disorders in the acute phase. Why is it that benzodiazepines fail to show efficacy in long-term studies? It's because of tolerance. Meaning, the more you utilize a benzodiazepine for a longer period of time, the less likely they're going to have an impact in the area that they're working in, specifically in the what are called benzodiazepine receptor. Exactly. So meaning you're using it, it worked initially in the acute phase, then it becomes more difficult for it to continue to do its job. This is extremely important in your clients because many of them utilize benzodiazepines because anxiety disorders are rampant with co-occurring with depression and co-occurring with mood disorders. Actually, an increase in anxiety is a precursor to somebody that's actually having an increase in even hypomania or manic related presentation. So anxiety is extremely important in that discussion. So I just wanted to bring that information here. The tolerance is an extremely important component.
And I would say with that, one of the things to think about is younger people being prescribed benzodiazepines long term is a cause for concern because of they're going to build tolerance over time, longer time to be on that medication. The other thing is if they're on benzodiazepines, it's a lot harder for them to learn behavioral interventions and things that they can do to cope with their symptoms of anxiety and start to deal with underlying trauma and other issues. So benzodiazepines, I'm really glad Dr. Austin brought it up because it's something that we, just like with the opioids for pain, we see that there's an overprescription of benzodiazepines for the treatment of anxiety. And just because a doctor is prescribing it does not mean that it's the best treatment for that person.
Well said. Now let's go into toxidrome. So very, very complicated slide, but very important slide. So just to get everybody acquainted, I'm a toxicologist by trade as well as a psychopharmacologist. Toxidromes are an excellent way to determine what individuals have been exposed to based off of symptomatology. So how they're presenting, what symptoms they're exhibiting, a great way to identify what the individual took. And on the left-hand side, you see we name opioids, sympathomimetic, benzodiazepine, cannabis. Sympathomimetics, just for everybody's knowledge, include cocaine, amphetamines, cathinones. Cathinones are things like Flocka. And one of the things I didn't mention last time, the difference between cathinone and amphetamine is a basic chemical structure that makes them no different. They're almost identical. Hence why we have a lot of cathinones on the market now, because amphetamines, for the most part, have become illicit and illegal. So cathinones have become very easy to manufacture. Nevertheless, the three of them are in the sympathomimetic categories. So to acquaint everybody with the graph, on the top of the figure, you have heart rate, blood pressure, respiratory rate, temperature, pupils, bowel sounds, diaphoresis. And on the left-hand side, you have anticholinergic, cholinergic, opioid, sympathomimetic, sedative, hypnotic. Let's discuss opioids, because that's what we're discussing here today. An opioid is anything, and you see the different ones in the opioid category, that activate the opioid receptor. The opioid receptor is relegated to areas in the brain, areas in the spine. And let's see what happens. If you activate the opioid receptor with any of these opioids, morphine, heroin, oxys, fentanyl, methadone, you will result in a decrease in heart rate and blood pressure, decrease in respiratory rate, a decrease in temperature, pinpoint pupils, absent bowel sounds, and dryness. And that makes sense because you've seen a patient who presents who's using too much of an opioid. The classic presentation is pinpoint pupils. One of the things that worries us as clinicians is that if you overdose on an opioid, you will potentially die because of the decrease in respiratory rate, resulting in respiratory depression and potentially cardiac arrest. Makes sense. So now somebody who is using, that's how they present with what you see in front of you. Now, if you are withdrawing, and many of your clients may have this situation, it's the opposite. You have increase in heart rate, blood pressure, increased respiratory rate, you have hyperthermia, you have dilation in your pupils, you have diarrhea and vomiting, and you have sweating. So the opioid, the reverse, is what you see in patients who are withdrawing. And this makes it easier for you to understand. So if you have clients who are presenting with pinpoint pupils, where you would have to ask yourself, obviously they have too much of an opioid in the system. But this should not be the case with patients on Subutex and Suboxone. Now, if you have somebody who has dilated pupils, it would be the case that your client is truly withdrawing. And you would be able to correlate their discussion and saying, you know what, I don't feel well. I feel like I'm withdrawing. And you can actually see it with the symptoms they have. Now, finally, I mentioned sympathomimetic because the truth is that the majority of the patients we treat on an acute setting and chronic setting are actually utilizing sympathomimetics at the same time, like cocaine and amphetamines. And look at the toxidrome. If you utilize cocaine or any sympathomimetic, the result is increase in heart rate, blood pressure, increased respiratory rate, increased temperature, dilated pupils, increase in bowel sounds, and sweating and diaphoresis. The complete opposite of the opioid picture, making it extremely challenging for clinicians on the acute setting to separate what presentations this patient has, because the way it is now, the majority of the products out there are actually using, if it's cocaine or a benzodiazepine, it actually has fentanyl in it. So it makes it very challenging to assess what is the primary presentation you're faced with.
And so to recap, what you see here are the symptoms of somebody who is under the influence of that type of drug. So what you would see in terms of their heart rate, whether it goes up or down, diaphoresis is sweating, whether they're sweaty or not. So when they're going through withdrawal, you're going to see the flip side of each of those. And then what happens is, though, the people that we work with are using multiple substances, so you're going to get this mixed picture. But it's a good guide, especially if you're in the home and you're trying to figure out what's going on, what you're going to be seeing in terms of physical symptoms. We're going to go over a couple of case studies. This next one is the case study of John, who is a hold on a second, why aren't you working? There we go. Okay, so this is really common, I think, that people get put on, they get prescribed pain medication, and then they start to abuse the pain medication over time. So this is somebody who had lower back pain 3 years ago. He started being prescribed extended release morphine, and then over time he continues to use it twice daily, right? When they went and checked, he hadn't been using any other controlled substances other than the one that was prescribed. John went into his doctor to establish care. He wanted a new physician. And then so when the doctor starts talking to him, he says, you know, number one, I've been using it a lot longer. Sometimes when I run out, I get really bad nausea and diarrhea and feel really achy. Does that recall the toxidromes? When he's run out of pills, he's been unable to go to work. And he's tried to stop, but he hasn't been able to. And then when the doctor asked him about using other medication or other ways to treat his chronic pain, because we know that long-term use of opioids for the treatment of chronic pain is not effective. There's other methods, but he feels like, you know, those things aren't for him, or he hasn't tried them. So the question to everybody in the virtual room is, does he meet criteria for opioid use disorder? And everybody's raising their hands, and we're going to say that yes, he does. He's meeting 2 or more of the DSM criteria within a year. He's taken the opioids longer than was intended. He's tried to cut down and has not been successful. And he's had some issues with work, not being able to attend work. So it's affected his functioning in at least one area. And the people that we work with, you're seeing functioning is affected in terms of school, in terms of family, you know, multiple issues, including having your children taken away because of your substance use. Wanted to point you guys out, ASAM is used to determine level of care placement. It's much like the locus, specific though to substance use disorders. What's important about ASAM is the dimension. So you're not looking at the person as just one thing, which is the addiction component, but you're looking at what are the biomedical conditions in dimension 2. So if the person is pregnant, that would be really really important to look at in terms of their placement, in terms of what level of care they needed. What other conditions are going on from an emotional, behavioral, cognitive issues. If somebody has had a traumatic brain injury, how does that affect? Looking at readiness to change in dimension 4, we're going to talk a little bit more about that. And look at dimension 6, remember Rat Park, we're looking at what the recovery or living environment looks like. So ASAM allows you to, it's an algorithm to put these 6 dimensions together and come up with a rating as to what level of care we believe the person needs to be. So this is a continuum of care according to ASAM. So we go from early intervention, which is the least restrictive, all the way to medically managed intensive inpatient services when that is needed, okay? One thing that you don't see in here is detoxification. ASAM does not consider detoxification to be treatment. Detoxification is the medical management of addiction, and inpatient detoxification is with a medical oversight, is really for people with alcohol use disorders and benzodiazepine addiction, but not necessarily for opioid use disorders. And some of the medical management of detoxification can be done in an ambulatory setting. So when people come in and they say, oh, I need detox, they've gone to detox multiple times, but they've never actually been discharged from detox and engaged in treatment. And so that's, I think, where all of us come in and really helping somebody and get involved in the treatment that they need. This graphic is one of my favorites. It comes from the Recovery Research Institute. The website is recoveryanswers.org. It's out of Harvard University. It is a website rich with tons of research and different information on working with addiction and really promoting recovery. So what I like about this slide is it has the stages of change, and then on the bottom half of the slide, it looks at different interventions that you might do depending on which stage of change the person is in. So for example, if someone is in the pre-contemplative or contemplative phase of the stages of change, we're going to focus on trying to do harm reduction, trying to engage them in treatment. Our emergency department programs are like that. Some of the work that you do in FEP and FIT is really, okay, there's an issue, let's talk to you about helping you to get into treatment. That's what happens in that phase. We have 2 more case studies we're going to go through really fast, but just to have you kind of think about, this is Tracy. These are clients that we actually worked with. Names change, of course. 22-year-old who has been using intravenous heroin for 2 years, also using cocaine, benzodiazepines, and cannabis. So think about what the clinical picture looks like when she comes in. But she's been using drugs since she was 13 years old. She currently lives with her parents, who are both using drugs and alcohol, and 3 other half siblings, all of them using drugs. And there's also a 2-year-old child, not her child, but a 2-year-old child in the home. So besides all of these other issues, and she came into treatment because her boyfriend died of a drug overdose. But one of the things that we want to look at, obviously, is what is the safety of that 2-year-old child. So for us, she comes in, we get a full clinical picture of what's going on with her, but we also determine that there's a child and potential harm in that home environment. So our first go-to is make sure that we're ensuring the safety of the child, and that we call the abuse hotline for that family.
Before you continue, I want to bring everybody's attention to the medical history and symptoms. You see that they have a Hep C diagnosis. If you recall earlier, I said with the rise in fentanyl and heroin use, we've seen increases in Hep C, HIV. So this is very classic. Episodic rage, that's interesting. Depression, characterized by PHQ-9 of 20. Has periods of 2 to 3 hours of sleep and no fatigue. That's actually a classic description that we like to use in separating somebody from what we call unipolar depression from potentially a bipolar depression. A very important and easy way to separate out an individual who has unipolar depression, meaning just depression, versus a bipolarity is that simple question of sleep. If you have sleep and you're depressed and you can't sleep,
great point,
and you're extremely exhausted afterwards, that's more representative of just depression. if you have very little sleep, because you're going to ask them, how's your sleep? Oh, I slept 2 to 3 hours. And then you're going to move on. But if you ask, but do you still have energy? Meaning, are you fatigued? And the answer is no. That's an indication of somebody that has a history of bipolarity, meaning history of mania and hypomania. The treatment of those patients, it's different than the treatment of patients with just unipolar depression. Moreover, if you have a bipolarity, and if you look at what she's using oxys, cocaine, and benzos, classic uppers and downers to manage their own bipolarity symptoms. So it's very good to see that information, and it leads you to believe I have somebody here that's never been treated for a bipolar disorder. And she's 22 years of age, perfect age to have a diagnosis, and she's probably had this for years without being diagnosed.
We had a question about what the PHQ-9 is. It's a patient health questionnaire, and the 9 refers to 9 questions. This is relevant because it is used widespread in actual and primary care settings. So doctors' offices, just a regular, I'm going to see my primary care, we ask them these questions to find out if there is undiagnosed depression. Very often people go to their primary care doctor when they're experiencing depression, and that's the first place where they seek help. So it's really important to screen for depression early, and so that we can start treating it. Why this is important in this case is based on her score, which is the PHQ-9 of 20 means like a moderate to severe depression, right? So it's concerning. She has high levels of depression. But if we only looked at that, we would miss the fact that there's other things that are pointing to the fact that she is actually bipolar. And one thing we don't want to get too far off into this, but people who have bipolar disorder, and I'm sure many of you have heard of bipolar, spend the majority of their time not in the manic stage where they're like super happy or have lots of energy or maybe hallucinating, but they're actually spending most of their time in the depressive state, and their lows of depression are very, very low. So in this case, it took us about 3 or 4 tries over the course of a year and a half to get Tracy stabilized in treatment. And one of the things that was key to that is having her on a long-acting injectable medication for her bipolar. So a once-a-month injection, which treats the ups and downs of the bipolar, helped her to really embrace or start the process of long-term recovery. And there were so many family dynamics, so many things in play here. The other piece with the hepatitis is that hepatitis C can be treated now. So as we start to treat, the person gets stable from the addiction, we start to deal with the psychiatric issues, we concurrently are starting to address the physical symptoms, get them involved in preventive medicine, primary care, and then eventually go to infectious disease so that they can get treatment for the hepatitis. I'm not going to spend too long on Carmen, but in her case, she's older, she's been in prison, she is not working, has issues with also hepatitis C and bipolar disorder. And in her case, she's lost custody of her 13-year-old son. But this is another complex case that we worked with that really took us a very long time to stabilize. In her case, and she was older, she would start treatment for her bipolar disorder, but then she would disengage for treatment. And at this point, she is lost to care for us. She had some periods of stability, but then went back out again. So she was much more difficult case. Looking at the ACE score, just see, we do track the adverse childhood experiences scale on all of our medication-assisted treatment patients. And what we found when we did an analysis of our data, that the people in treatment have much higher, significantly higher rates of exposure to adverse childhood experiences than the general population. We can talk more about that after, but just wanted to give you that fun fact. So what is medication-assisted treatment? This is something for you guys to really keep in mind, because a lot of there are physicians out there who are prescribing Suboxone or Subutex. You go to a doctor, he gives you a prescription, you go on with your day. Medication-assisted treatment is not that. It's looking at the whole person care, and it's integrating the behavioral health and the psychological interventions along with the medication. So the medication isn't given just So you might go in the home, you might test someone, they're positive for buprenorphine. They say, oh yeah, I have a prescription for that. You call the doctor, they verify the prescription, but is that person really involved in a recovery program? Are they really in substance abuse treatment? And I would venture to say that they are not, that they need more services and more intensive services, especially if some of you are in the home because of potential child abuse and neglect due to the parent's substance abuse. So there's 3 medications that are approved as part of medication-assisted treatment.
And I'll discuss them fast. If you guys have questions afterwards, please ask them. Many of you probably heard of methadone. Methadone has been around for a long time, many decades. Definitely has a place in treatment, but things have changed. We have buprenorphine now, some of the products like Subutex, Suboxone, which many of you know of, and then we have naltrexone available orally with Brivia and injectable as Vivitrol. I could discuss that in a minute. Just to acquaint you with the class, I think it's an important note on the second line: methadone being a full agonist, buprenorphine being a partial agonist, and naltrexone being an antagonist. Just to understand the words, agonists mean they fully activate that opioid receptor. And we had this discussion last time. Basically, there's no ceiling effect with methadone. You can start off with 10 milligrams, and we've had patients that are all not our patients. Patients present with doses of 300 milligrams, and meaning the more you take, the more that you get activated at that receptor. The difference in activity at the reward pathway in the opioid receptor, no different than being on any other opioid, morphine, or anything else activating that receptor.
And what you see on somebody of high doses of methadone is somebody who looks high, somebody who's nodding out, somebody who is potentially using other drugs as well, because there isn't the same thing that you have with buprenorphine.
And buprenorphine, on the other hand, is a partial agonist. The fact that it's a partial agonist means, very simply, it activates the receptor. However, at certain doses, it has what's known as a ceiling effect. And after it reaches that ceiling effect, it starts to antagonize the same receptor. Moreover, the fact that it's a partial agonist means that once buprenorphine is bound to an opioid receptor, it will not allow other opioids to bind that receptor. Hence, if you have somebody on buprenorphine products and they take another opioid, there's a possibility that they'll precipitate their own opioid withdrawal. So buprenorphine is very interesting for that matter, which is why it's actually become very successful with patients in MAT services. And then lastly, naltrexone is a full antagonist, meaning it binds to the receptor and it blocks other opioids from binding it completely to that receptor. So that's a little bit about the class and how they're different.
And fun fact about Vivitrol, it's also used for people with alcohol use disorders, not just opioid use disorders, right?
To acquaint yourselves back to the original slide, we talked about the reward pathway. One of the receptors in the reward pathway allows for alcohol to release natural endogenous opioids. Alcohol actually releases natural endogenous opioids in the brain that mimic the effects of opioids and activate the same opioid receptor in the reward pathway. Hence, that's the pathology of why alcohol becomes addictive, and that's why we use naltrexone in alcohol use disorders.
Nice.
So now this is just a general variety of formulations available, and this sometimes is very challenging. One of the things that to keep in mind in the next slide is that we have a slide on clinical use and ideal candidates. This used to be more important in the past. Not anymore. Anybody's an ideal candidate at this point in time for buprenorphine for the most part.
So one of the controversial things about medication-assisted treatment is that people say, oh my God, they're going to be on this drug forever, or it's so much harder to get off than heroin. It's not a one-size-fits-all. So one of the things to keep in mind is that there's a phased approach. Basically, we start somebody on medication, and then there's a plan for at least having a conversation with them about reducing the dose of that medication over time. A lot of what we see in private practices where they prescribe Suboxone is that they prescribe very high doses, and what would be a typical high dose, 16 milligrams, 24 milligrams.
Right.
Yeah, even 12 milligrams. We work with people when we start them. The majority of people start at 8 milligrams of Suboxone, just to give you a little clue of what to look for. And then because we start on a lower dose, it's easier to bring the person down. So not a one size fits all. Some people may need to be on a low dose of Suboxone for a long period of time. Some people are able to get off it much sooner. We're going to quickly go through what the components of a MAP program are. Hold on one second. Why aren't you responding?
It froze.
Hold on. All right, here we go. So what to look for if somebody is involved in medication-assisted treatment. One is treatment is comprehensive. It isn't just the medication, it's medication plus the behavioral interventions, plus including psychotherapy. So recovery support, case management, all of these, care coordination, all these pieces together. Making sure that people are being screened appropriately and assessed to see what the best treatment is for them. Monitoring illicit drug use. A lot of these private practices are not monitoring them for ongoing, whether they're actually taking the Suboxone, which they should come up in their urine drug screen, but also what other drugs are they taking. Looking at treatment that is multidisciplinary. So there's more than just just addiction treatment, but you're looking at psychiatric, you're looking at OB if the woman is pregnant, you're looking at primary care, all of these pieces working together to deliver services in a way that treats the whole person, and then making sure that treatment is accessible. If somebody wants to start treatment, they should not be having to wait a month for an appointment, 2 weeks for an appointment. That's way too long. So for us, accessibility is really important, which is why we have our access to our medication-assisted treatment program is through the emergency department. Oops. This is just a slide on what are to conceptualize a recovery-oriented system of care. Bottom line is all these pieces are working together in the best way possible. And that's what, we got 9 minutes. That's what we're trying to do in our program, and which is why we're feel so fortunate to be presenting to you today. Really important, monitoring for compliance and diversion, just something to keep in mind.
So we had this quick discussion last, so I'll spend a couple minutes on this. One of the things to keep in mind when we're looking at toxicology screens, there's a difference between what's known as qualitative or quantitative analysis. Here you have a general picture of what somebody might be looking at when they're looking at a drug screen and kind of what's happened. The biggest take-home message I like to really lay down for toxicology screenings is that it's very challenging. There's a lot of factors that can affect screening. One of the things that we face and many people who do screens is are we doing observed screening? Are we ensuring that there isn't anything being put into the canister to deter detection, which is very common? There's now the use of, this is rampant, prosthetics that make it look like you actually have something that mimics the genitalia, and you're using that to divert.
And it's somebody else's urine.
It's somebody else's urine. So there's a lot of factors that go into this. So to me, the biggest take-home message when it comes to this is to really, a lot of people, not just those in the community, not just those in the practice, maybe those listening, even experts have a challenging time making heads or tails when it comes to toxicological screening. So it's something that really deserves a thorough discussion at a later time, hopefully.
And next is just a quick 5-minute overview of what phase treatment is. So again, not a one size fits all, but that the person, the concept of somebody moving through phases. So engagement phase is what a lot of you are doing in the community, really starting to look at what treatment is going to look like for that person, finding the right fit for a place where they can get treatment, starting to do motivational interviewing and looking at the stages of change of how we can start to motivate people into coming into treatment, right? Induction phase, that's when you actually work to when you get the person off of the street drug or off of the pills and onto, in this case, Suboxone, which is what we do out of the emergency department. In the induction phase, we want daily monitoring. We don't give someone 30 days worth of Suboxone, or even 2 weeks or 1 week worth of Suboxone. They have to come each day so that we can monitor them for withdrawal and work on increasing their motivation to be in treatment. And that this is really important. And this induction phase is when you really want them, like a lot of services. This is where recovery support becomes really important, where care coordination is super important. So this is the induction phase, is basically getting them started on the Suboxone. This is what we use to monitor withdrawal symptoms. If you look at the areas, they correspond with the toxidrome talk that we had, the runny nose, the pupil size, sweating, all of that is related, and it's how we do a daily CALS every time somebody comes in to get their Suboxone. We monitor to see where they're at in terms of their withdrawal, because this allows you to adjust the dose if you need to. In the stabilization phase, we're looking at controlling cravings. What are their triggers? Coming up with a really comprehensive recovery strategy. What are some of the medical and psychiatric issues that are going on? So by the stabilization phase, they're on a stable dose of the Suboxone. And then we move into maintenance, which is like this longer term phase where we start to really address what's happening in terms of their personal life, in terms of trauma, in terms of family. How do we get them to help build a life worth living? And then finally, we have the long-term rehabilitation and discontinuation. This is when we really look at, you know, how do we start to step you down off of the Suboxone? And for a lot of our patients, we come off the Suboxone entirely and then switch to Vivitrol. In this phase, we want, again, more intensive services, a lot of peer support, because they're going to need it. There's a lot of fear around withdrawal symptoms, and am I going to experience withdrawal? And some people say that those last 2 milligrams of Suboxone are very difficult to come off of. And with that, we have concluded our talk with 4 minutes to spare for questions.
Excellent.
And Sam, if you want to take people off of mute so that we can ask questions.
Yeah, I'm trying to figure out how to do that, or if they have to do that themselves.
Do you need me to stop sharing?
Maybe you can try that, but I don't know. Does anyone have any questions?
Sam, it's Ashley. I was able to unmute myself, so if people have questions, they can just unmute themselves.
Hey, Ashley.
Hey, Ashley.
Hey.
You have a question?
No, I was just checking to see if they could unmute themselves.
Thank you for the help.
Anyone?
So I guess we answered every single question in our really fast presentation.
All right, well, there are 65 people here, so I mean, if someone...
We might have put them to sleep. It is close to lunchtime.
I think that their reward pathway is being triggered.
And they want to get off this call. That's okay.
All right, well, if no one has anything, then I just want to thank you guys so much for doing this for us. Super educational, super informative, and I will be sending out the PDF of the presentation to everyone that attended, so you have it to reference in your upcoming work, and all their contact information is in the presentation.
And we want to thank you, everybody, for the work that you do in the community. It's so important, keeping children safe. And you know, it's so important that we work together, and we commend you for the work that you do. So please stay safe out there.
Thank you, guys. Thank you, Sam. Thank you.
Thank you so much. Great presentation. Thank you so much. I really appreciate you guys taking the time to teach us. This was really very, very informative.
Thank you.
Thank you. And we will be doing talks in the future. So, you know, connect with Sam if there's educational issues that you guys would like. We want to take this to more like a round table or more Q&A type stuff. There's definitely going to be the forum to do that in the future. Okay.
Perfect.
Thank you.
Thank you.
Thank you, guys. Everyone have a good weekend, okay?
Thank you. Bye.
Bye.
Bye.